Hi, I am Brian Varula. Welcome back to my final video 4 on my gold standards for COPD excavation special projects. Uh, we will be specifically talking about the different, more in-depth talks about the so-called rehabilitation, the rehab, the oxygen therapy, ventilatory support, the surgical interventions, and symptomatic care for COPD patients, and what it might all entail. So, pulmonary rehab, what does it do? Pulmonary rehab is to benefit COPD patients. We briefly went over this before, but basically it is considerable for rehab and has been shown to be the most effective therapeutic strategy to improve shortness of breath, health status, and exercise tolerance, because you're being pushed to your limits, you're being pushed to do better, you're being pushed to actively train those muscles that haven't been used in a while, or if they have been used, they have been used to the extent that they need to, and furthering your body to be more adaptive to the oxygen that it needs, to the certain situation that it might be in. Pulmonary rehab can also improve your difficult breathing, your health status, and your exercise tolerance, especially in stable patients. But the main thing is that we don't want you in the hospital. We don't want you having these exacerbations that can happen to most of your patients. It can happen right away. It can happen to a trigger of whatever allergic response they may have, or it could be a trigger from, let's say, they needed to run and get something and they're out of breath, or they're simply just getting up and walking to the bathroom. We don't want that to be a life-changing, life-altering event, but rehab can help develop sort of like a toolbox for the patient to use in certain situations in their daily needs. It also provides education and self-management. A lot of people diagnosed with COPD aren't very aware of what entails what their life holds and what they should normally experience in their regular daily lives, and this can help not only the patient but their caregivers, their family members that are involved, and they want the best for them. So this could really help with the self-management intervention and to communicate with them. This will also decrease hospitalizations. This will also decrease department visits, because if you have a family member or the patient themselves know to understand what to do in a certain situation that they can handle at home, they can. So it's an integrated care program. So telehealth, and they have no demonstrated benefit at this time. So to integrate care in telehealth, in the further future, this could be a very good thing for the patient. So they could have, these online visits that they don't need to have in person just to see how the patient's doing. Especially if they're involved in rehab, they are already being seen by, hopefully RTs and hopefully physicians there and the nurses there, and they're being held accountable to maintain their regimens and stuff like that. So symptoms control, it's a very symptomatic, COPD is a highly symptomatic disease, so it has many elements, it has many factors that cause fatigue, that cause dyspnea, depression, because the life they used to live is no longer theirs, or it's no longer in their grasp in that moment, anxiety, insomnia. And those are big things, because if you're anxious, you can't breathe, you're anxious. And if you can't breathe, you can't sleep. So this is a very rapid deterioration of functional life and daily life necessities. So a lot of people end up, especially the more severe ones, end up in sort of a palliative treatment care. That's not something that we want for our patients. That's something that we want right away. But palliative approaches are essential in context of end-of-life care. So, as hospice care is coming through, we want to be able to help these patients live a normal life without pain, without that stress of knowing, like, can I catch my breath? am I able to live the next few minutes? You know, they want to be able to know that, hey, at least if I only have 6 months, at least there's how many months or weeks or years. They want to live to the extent to that. You know, they don't want to be held down knowing that maybe tomorrow will be the last day and not 6 weeks from now or not 6 months from now because they weren't able to, you know, catch their breath. So how can we control their symptoms? Well, you know, the pulmonary rehab, it's a big one. They're getting daily necessities. They're getting their weekly needs. They're getting their weekly exercises in, especially people that are not terminally ill. So they're getting their, you know, constant visitations at the office to their, you know, primary care physicians. They're seeing they're making sure they're taking their medications on time. They're understanding how to use their rescue inhalers whenever they need to. They're understanding that there's certain at-home broncho hygiene therapies that they can use, like flutters and ISs, and you know, even to the extent where they can't even get a good cough in, maybe they might need a cough assist, you know, something that can help them expirate their sputum, the mucus that they are retaining, and to know when to come to the hospital, when to come to the ER in those life-changing moments and those life-threatening moments. I mean, so we just want to make sure that we're giving them the needs, giving them the tools and the education for them to use. So oxygen therapy and vent support, you know, both almost one and the same, but one is very much drastically different than the other in the sense of how it alters their life. So most COPDers are going to need oxygen therapy. It's just the way of life for them. They might need 2-liter nasal cannulas. Some might need more than that. Some are going to need non-invasive support. You know, it's all just very individual. It's very personal to the person themselves. Let's say they might have a long-term administration of oxygen. This increases their survival in patients with severe chronic resting arterial hypoxemia. So they have very low PaO2s. They're going to need oxygen. That's just how their life is going to move forward. In patients with stable COPD, a moderate resting or exercise-induced arterial desaturation, so they might be prescribed long-term oxygen. That does not lengthen the time to death or first hospitalization. It provides the same benefits and health status. So lung functions and 6-minute walk distances are very essential to determine, hey, like, how much are we actually going to give them? How much oxygen do they need at home or with them on person? So how severe is it? That's basically your assessments that you're doing there. And then your resting oxygenation. How are they sleeping? How are they when they're just sitting down or when they're laying down? And then developing a sort of care plan with that, because if they're severe, they're going to need to have air with them all the time. So even when they're sleeping, ventilatory support. So this is really great for people that, you know, even though they have that oxygen, they still need that extra support throughout the day. So a BiPAP machine, a CPAP machine for nights, it's critical for their survival, because if they are in a position where they can particularly make it to the hospital right away, they have that support there for them to help them along their travel, along their self-care at home. So surgical interventions. So of course there's going to be some surgical interventions towards some COPDers that need that type of correction. So lung volume reduction surgery improves survival in severe emphysema patients with an upper lobe emphysema and low post rehabilitation exercise capacity. So I mean, these are pretty severe people that are to a point where it's like, hey, you know what, we see that you're putting the effort in, we're seeing that you're trying, but you still need that extra help. You need this extra care measure. So we're going to go ahead and just do a reduction surgery. You know, especially if it's emphysema, you have all that flappy, overstretched lung. You know, getting all that weight off to allow your lungs to expand a little bit better could be very, very positive treatment for them. But of course, you know, that's going to come with the post rehabilitation exercise capacity. So you're gonna have to really work hard after that surgery as well. Bulectomy. So in some patients, it's associated with decreased dyspnea, improved lung function, and exercise tolerance. So you're seeing a good increase in lung improvement functionality. And a better exercise tolerance. Transplantation. See, these are people that have really necrotic lungs, but they've done their work and they've done their time by going to rehab, staying off the smokes, taking care of themselves, eating well, exercising well, being communicative, being in a community where they're, loved and they're being held accountable. So that's one of the big things too. And then bronchoscopic interventions. This is in select patients with advanced emphysema. Bronchoscopic interventions reduce inexpiration lung volumes and improve exercise tolerance. So their health status and lung function at 6 to 12 months following that treatment could be better. It's improved. So their endobronchial valves and lung coils are, these are the sort of treatments that you'll see. And again, I don't know if you see it trained here, this is all advanced emphysema patients as well. So there's not a lot of treatments to go around, and that's why it's very important that when you have these first-time smokers, these first times, these young kids or these young adults that are seeing these things happen, and they're not understanding like, oh man, my life will be fine. I'll be okay right now, even though they're sacrificing their future to live a certain lifestyle, when they could have avoided all of this type of treatments to live a better life. Well, thank you for today. Thank you for joining my video. Thank you again, and hopefully you learned everything you need to learn. Thank you.